Dr. Zych here, talking about his article, Functional Bracing for the Treatment of Fractures of the Humeral Diaphysis. Can you start off with talking a little bit about what led to the development of this study and kind of where you were at in training at the time?
Yes. Dr. Sarmiento was my chairman when I began the orthopedic residency at the University of Miami for 2 years. And then he was recruited to University of Southern California, LA County. So I worked with him for 2 years as a resident. And I actually did 6 months of clerkships prior to being selected for the residency at Miami. So I worked with him also during that time period. But I was a full-time member of the faculty since 1980.
And can you talk a little bit about the main findings from the study?
Well, the main findings were that we discovered that the functional treatment of humeral shaft fractures was very effective. We had a relatively low non-union rate. There were anatomical changes that were present in some patients, and that's been detailed in the article. So often the anatomy can be preserved fairly well. Sometimes, particularly in arms that are very obese or in people who are very muscular, they tend to keep a deformity of the humeral shaft, yet they still achieve healing. So we wanted to study our experience at Miami and Dr. Sarmiento's experience at USC, combine them to see if our statistics were similar, since we basically were treating the urban trauma population in both locations. And we discovered that if you follow the patients very closely, that this could be a very effective treatment for isolated humeral shaft fractures.
Union rates you all had in the study, 97%. More recent studies, we really haven't been able to reproduce that. Do you think the patients are changed? How surgeons are treating patients has changed? We're doing it wrong? Just comments on that.
Yes. Well, as I said, we follow the patients very closely in a special fracture clinic every Thursday. We didn't see them every week, but we did see them very often. And we had a certain protocol that we followed. This was developed by Dr. Sarmiento and some of the faculty staff, whereby patients would be initially immobilized in either a coaptation splint or sometimes a long arm cast. And then at approximately 2 weeks, they would be switched to a humeral fracture brace. Later on, we discovered that in a certain number of patients, you could just put them directly into a humeral brace, and they did very well. But that was our initial protocol. And then they would maintain an arm sling for 2 weeks, but we would encourage them at all times to actively move their hand and fingers to help resolve the edema that you would have inevitably after a humeral shaft fracture. Once they were transferred into the brace, we then permitted them to have gravity-dependent positioning of the arm and encouraged them to actively flex the elbow. So we activated the biceps muscle. The triceps muscle was basically activated by the fact it was an antagonist to the biceps, and gravity alignment of the arm actually helped maintain the reduction or achieve a reduction to some extent. Then they were followed roughly every month with radiographs, sometimes sooner, depending if they didn't fully understand the functional treatment that we instituted for them. And basically, we followed them out as long as we possibly could in this urban trauma population.
In your current practice and over the years, are most of these people getting at least initial non-operative management, or who all are you treating with surgery early on, and how are you counseling them?
Okay, well, for isolated humeral shaft fractures, we still think non-operative management is indicated, and we continue to treat them with the humeral fracture brace. We don't do this for multiple trauma patients. We don't do this for patients that are considered non-compliant. We certainly don't do it for patients who have both upper and lower extremity injuries, or if they have ipsilateral upper extremity injuries then we think that's an indication for surgery.
When is it most common throughout their treatment course if you start with non-operative management? Are you switching to surgery?
It's more based on the radiographic findings and how the patient's doing.
Yeah.
If they're really having a very difficult time with mobilizing their upper extremity, then we might consider operative management at that point. If we see that there's absolutely no healing in a progressive manner, then that's probably another indication to go to surgical management.
Any comments on some of the more common mistakes surgeons are making when they're trying to treat patients non-operatively and having issues?
Yes, I think the first point is that the patients must use an arm's length for the first 2 weeks. They have significant edema in the entire upper extremity. And if you let the extremity hang down in a dependent position, it goes into the hand, and then they end up with stiff fingers and stiff wrists. So we really need to emphasize the use of an arm sling for 2 weeks. After that, if the patient is put into a humeral fracture brace, they really need to understand the correct application of the brace. There's only one way that the brace goes on the arm, and it's very important to initiate that functional treatment like I talked about previously, where we now start to activate all the muscles of the extremity to actually aid, I think, in the secondary callus that forms.
Any adjustments looking back at this study that you all would have made in the design?
Yes, I would say we tried some changes. For example, we thought maybe in the more proximal third shaft fractures that we would put a sleeve or a almost looks like a part of a shoulder pad over the shoulder in an effort to maintain the reduction better. But we discovered that that had no effect whatsoever on maintaining reduction. And in fact, it led to more stiffness in the shoulder. So we abandoned that idea. The other thing is that it may not be necessarily wise to put a patient in a coaptation splint if they have minimal swelling, they're not terribly painful. You can apply a humeral fracture brace immediately, and actually they're quite comfortable in the brace in addition to the arm sling.
Any of these patients that have had soft tissue problems and wounds that develop in the Sarmiento, or do you feel like that can really be avoided with the close follow-up that you're performing?
I think so, but we also emphasized that they needed to have clean stockinette under the brace at all times and to make sure that it extended beyond the edges of the brace. And a lot of this has to do with the proper wear of the brace. It's a relatively demanding technique, but the results I think can be very gratifying in the correct patient.
Well, thanks so much for joining me today, and we appreciate your contributions to the field.